Hello, and welcome to Roly Poly Weight Loss. I'm your host, Roly Poly. Welcome to day 27. So, let's get started. Okay, so before I jump into our topic, I wanted to do a check-in. It is important to check in with your process and your progress every so often. It is one thing to make goals, another thing to keep yourself on track for achieving them. Now, too often, this is the problem with New Year's resolutions. By the end of January, we've stopped thinking about them, and we don't check back in. You might have forgotten or fallen off the wagon or not made as much progress as you would have liked. But a check-in lets you refocus and re-strategize. If you let things continue to slide, you'll never hit that goal. And I forget where I heard it, but I loved this metaphor. If you drop your phone, you're not going to decide it's gone and walk away, or that it's ruined and start stomping on it. No, you're going to pick up your phone and go back to using it. So if you stop working out, start up again. If you break your diet today, start again at the next meal. If you stop losing weight, assess why. Make a new plan. If your goal needs to change, adjust it. Don't just leave the phone on the ground. And I'm guilty of this myself. This is the reason why none of my past things have continued to this day. At some point, I stopped for one reason or another. So we're going to do the same thing here today. It is time for a check-in. I've been doing this for just over 2 months real time, and that's awesome. That's also just much further than some of my other plans have gone. Okay. Water break. So, the first month, I noticed some real progress. I lost, I believe, 3 or 4 pounds. And the weight was creeping off, but it was actually coming off. Now, this second month, that has changed. And I know that at the beginning of the month, I had a wonky week, and I expected that. But I expected it to be the exception, not the rule, for the month. So I thought through it, trying to find the differences in the 2 months. And the difference I found was no 0-day May. Without tackling my eating, which we are now starting, just doing this cardio exercise for 20 minutes 3 times a week clearly isn't enough to make a difference on my body. And back when I was also walking every single day for half an hour, that's when I was losing weight. And it isn't just the weight. I was sleeping better and I had more energy in May than I did in June. So I'm going back at it. My goal is to walk, trampoline, or bike at least half an hour a day for this month, and see if that gets me back on the losing track. I'm also aiming for one of my life goals, which is to get back into walking 5Ks, like this one. And more than that, I want to actually be able to jog and eventually run them, which for me is a big deal. This is something I thought a lot about when I did my personal goal journaling, as I talked about in week 5, figuring out your motivation and your goals and your plans. I have started a partial bullet journal. I'm very proud of it. I will share some pictures on my Tumblr. But I've been doing a lot of thinking about what my goals are, both short and long term. And as I said, this 5K one is one of my big goals. I have talked about, and I will continue to talk about, the fact that I was walking 5Ks before. But I really mean walking, coming in at the end. And I want to be able to jog them. So I'm going to start a Couch to 5K program and work my way up to jogging and running. I'm very excited. This is a 3 times a week schedule, and I did my first one yesterday, so we'll see how that goes. Now, I was a little intimidated by most of the plans I looked at for Couch to 5K because they were in like a 9 and 10 week time frame, which is just 2 months or 2 months and a week. So I just doubled it. I'm going to be spending twice as long on each goal and giving myself permission to not have to rush. If it takes me 4 months instead of 2 to get up to jogging and running, that's fine. But that also means that 3 times a week I'll be, theoretically, making that half-hour walk either a full hour or a jog/walk as I work through this program. So look for those posts from me too. I'll also be getting back into doing 5K walks. So look for those posts as well. I already signed up for my first one in 2 weeks, so I am committed. I am doing it. And then finally this week, I'm trying to get into the habit of logging my food. Not changing anything, just eating what I usually would, but keeping track of it. We're going to start logging in earnest next week, but it's helping me to try to pick up the habit this week. So, timing. So, that is my assessment of my process and progress in the last 2 and a bit months and my plans going forward. So please take the time periodically to do your own assessment and tweak your routines and schedules as needed. Okay, check-in done. On to the topic, which is, sadly, one that I'm sure we're all familiar with, and not in a good way, which is fat shaming. Now, I'm not talking about trolls on the internet or looks in public or comments at the grocery store kind of fat shaming. This one is far more dangerous and hurtful, and that is medical fat shaming. I have been incredibly lucky, and so I didn't really realize this was a thing, because I have a family doctor who, it's a small town, he treats the rest of my family, known me my whole life, and then when the person he picked to take over his practice had a similar mindset, and so I kind of lucked out on that as I was through most of my process. When I moved out of town on my own, generally speaking, I didn't go to the doctor. But since I have now learned this is a thing, I'm looking back over my more recent trips to other doctors, and trying to see if it might have been there without me noticing it as much. Because sometimes it's overt and sometimes it's not. So, the reason I'm thinking about this is Samantha B. did an episode of Full Frontal a few months ago, which talked about this, and that's how I got clued in. You might have also seen it on Good Morning America or some of the other morning shows. Now, there are some great points from Good Morning America, and their doctor spells out something that needs to be just shouted from the rooftops. When I got board certified in obesity medicine, we learned the facts that we don't understand completely what causes obesity, but we know what doesn't cause it. It's not caused by laziness. It's not caused by a lack of commitment. And again, shout it from the rooftops. It's not laziness. It's not a lack of commitment. Unfortunately, they made one comment which I found to be true, if slightly missing the point, or at least today's point. So Dr. Jen pointed out that physicians need to ask to talk to us about our weight, give explanations for why they're making the suggestions they are, and actually help us make a plan to change, which is a rarity in doctors. But, and that's the good part, but she also notes that patients need to listen and understand that this is coming from a place of medical knowledge, not of societal meanness. And that is good and true, and we do need to listen with an open mind in those situations. But sometimes it is coming from a place of societal meanness, which is what we're talking about today. Earlier, in that very same segment, before that advice was given, Good Morning America read a tweet from a viewer who, at 160 pounds and 5'8", oversaw that her doctor wrote obese on her chart. Excuse me? Have you looked at a BMI chart? 160 pounds, 5'8"? She's in the optimal range for her height. That is not obese. That isn't a doctor thinking that she needs to lose some weight for medical reasons. That is legit fat shaming. So Samantha B gets more into this side of it. As she notes, one study found that doctors spend less time with obese patients, and they may fail to give them medically necessary tests, instead telling them they just need to lose weight. Doctors' fat bias isn't just rude, it's medical negligence that can kill people. So one of the articles she quotes is this one from the New York Times, and they have some shocking and sadly relatable stories. There was this 58-year-old woman who had already lost 70 pounds, which is amazing, and she was having hip pain, so she went to the doctor. He came to the door of the exam room, and I started to tell him my symptoms, Mrs. Neese said. He said, "Let me cut to the chase. You need to lose weight." The doctor, she said, never examined her, but he made a diagnosis, obesity pain, and related it to her internist. In fact, she later learned she had progressive scoliosis, a condition not caused by obesity. So he didn't even, examine her, touch her, barely looked at her, just decided, without even hearing her symptoms, your pain is caused by your weight, not even seeing that she had lost so much. Another woman from that article suddenly found it almost impossible to walk from her bedroom to her kitchen. Those few steps left her gasping for breath. Frightened, she went to a local urgent care center, where the doctor said she had a lot of weight pressing on her lungs. The only thing wrong with her, the doctor said, was that she was fat. Except, of course, obesity doesn't cause a sudden inability to breathe. It turns out she had blood clots in her lungs, which is, a life-threatening condition that this doctor just ignored. So, Healthline's article on Dr. Fat Shaming starts right off the bat with two women, both told that their back pain was from their weight. It turns out that one had injured her back several years before, and the muscle was deteriorating. And, bonus, all the exercise they told her to do to lose weight was making that worse. And the other one had ovarian cancer. Both conditions, it should go without saying, but apparently needs to be said, that have nothing to do with your weight. And this can also tie into eating disorders, which is an episode coming up. But as this patient notes, because I was fat when I first began dieting, and because I didn't present as emaciated even after I was in the throes of anorexia, every sign of my eating disorder was overlooked. She goes into more detail. Apparently her doctor kept congratulating her and telling her to keep it up, even when she was dangerously, fainting and stuff. And this also works in some ways in reverse, where there are some people who have metabolic disorders, but because they aren't presenting with the stereotypical weight gain, they aren't diagnosed. Because the doctors just don't look for it. Oh, that's a fat person disease. You're not fat, you don't have it. And the fat shaming doesn't even have to be overt. A study was done on this and recently published. Psychology Today quoted the professor who presented it. Disrespectful treatment and medical fat shaming in an attempt to motivate people to change their behavior is stressful and can cause patients to delay healthcare seeking or avoid interacting with providers. Presenter Joan Chrysler, professor of psychology at Connecticut College, said in a statement prior to the APA symposium. Chrysler added, Implicit attitudes might be experienced by patients as microaggressions. For example, a provider's apparent reluctance to touch a fat patient, or a head shake, wince, or tisk while noting the patient's weight in the chart. Microaggressions are stressful over time and can contribute to the felt experience of stigmatization. And again, some of these things aren't as overt as telling a patient to just lose weight, but it's so blatantly obvious to the patient that you think we're too fat. But unfortunately, as these articles and segments cover, the problem goes beyond just the doctor's personal fat bias. It's not just doctor fat bias, it's medical fat bias. So for example, CT and MRI scanners. Most have a weight limit in the 350 to 450 pound range. This is actually treated for laughs in an episode of House, where he puts the fat guy in the scanner anyway and it breaks. Now, they make scanners that can hold heavier people, but those are way less common than you think. Even bariatric surgery centers, you know, those places that give weight loss surgeries, don't often have them. 1 in 5 has them. Yet, CT or MRI imaging is needed to evaluate patients with a variety of ailments, including trauma, acute abdominal pain, lung blood clots, and strokes. When an obese patient cannot fit in a scanner, doctors may just give up. Some use x-rays to scan, hoping for the best. Others resort to more extreme measures. Dr. Kahan said another doctor had sent one of his patients to a zoo for a scan. If you think having a doctor tisk over your weight is humiliating, try being told you have to go to the zoo and use the elephant scanner. Now, even if you can get a doctor to listen to you and to figure out a way to diagnose what is wrong, you can run into complications with your medications. There are several cases of doctors missing cancer because of fat bias, but even when it is diagnosed, there are problems. Drug doses are usually based on standard body sizes or surface areas. The definition of a standard size, Dr. Hudis said, is often based on data involving people from decades ago when the average person was thinner. For fat people, that might lead to underdosing for some drugs. But it is hard to know without studying specific drug effects in heavier people, and such studies are generally not done. Without that data, if someone does not respond to a cancer drug, it is impossible to know whether the dose was wrong or the patient's tumor was just resisting the drug. Because they don't do studies on fat people, so they don't figure out what we actually need to do. There's also a problem with anesthesia. If an obese person can actually get their condition treated and it needs surgery, they can run into problems. There are no requirements for drug makers to figure out appropriate doses for obese patients. Only a few medical experts, like Dr. Hendrikus Lemons, a professor of anesthesiology at Stanford University, has tried to provide answers. It turns out that some anesthesias should be counted by lean body fat, not total body fat, and using average person numbers leads to overdoses for obese people. And this leads to complications after surgery. Oh, and you know why so many doctors won't do knee or hip replacements in obese arthritis patients until they fall below some magic and arbitrary BMI line? Because they don't want their percentage of complication-free surgeries to come down. Well, maybe if you gave us the right doses of anesthesia, we could help you with that. If you gave us the right doses of medication, we wouldn't have complications. That wouldn't affect your bottom line. What a concept! Now, as we all know, all of this medical fat shaming doesn't help. Well, science is finally on our side. Stigmatization of obese individuals poses serious risks to their psychological health. Research demonstrates that weight stigma leads to psychological stress, which can lead to poor physical and psychological health outcomes for obese people. One specialist even noted, "It's not unlike the way we treated depression 40 years ago, only instead of telling people to get over it, we say, just eat right and exercise." We know there are economic, cultural, political, and environmental elements causing this problem, yet our approach to treatment puts sole responsibility on the patient's behavior. So some doctors get it. And fortunately, they are growing more in number. But in the meantime, what can we do about this? Most of us might be inclined not to go to the doctor at all. I've certainly fallen into this category. But this can hurt us because we might put off life-saving scans or surgeries or early diagnoses. And if we do go to a doctor and they are the kind who just blames everything on our weight, that can be really discouraging. And that can discourage us from getting a second opinion. Not to mention that going to a different doctor can cost more, not only just for a second appointment, but if you have limited options and find one that you aren't covered under. So it can be really hard. And the onus is on us, for the most part, to find someone who won't fat shame us. Which, again, is not how it should be. But sadly, how it often is. So, Healthline offers some advice. If a practitioner automatically advises weight loss with no regard for symptoms or thorough examinations, one of my go-to responses is to ask them how they'd handle the situation if dealing with a thin patient. Would their diagnosis be the same? Would they prescribe weight loss rather than blood work, physical therapy, x-rays, or medication? If you're the type of person who's bold enough to ask that, try it. It might work. You can also ask not to be weighed, or give them a letter at the start. If you're not confident enough to speak to them, to their faces, you can give them a letter saying that you would like to focus on your health and your symptoms and not your weight. Those might help. If they don't help, finding a doctor who won't fat shame you is kind of your other option. And more of them are being trained in this, and it is spreading. There are now not only doctors being trained specifically in obesity or overweight medication or medicine. As the Good Morning America doctor noted, that's what her specialty is. There are also schools teaching this now, changing the way they train their students. And there are seminars and things aimed at practicing doctors to help teach them how to take care of their patients without fat shaming. So it isn't entirely on us. They are trying to fix themselves, but it is slow going. So in the meantime, it's kind of falling on our shoulders anyway to go find someone who won't fat shame you. Which isn't ideal, but not a lot is. So that is it for today. Like I said, heavy topic, but far too relevant. And if you are putting off something that you need to do because you don't want to go see that doctor, like a mammogram or a follow-up health check into something that you need to check on, please go see them, see someone. This has been Roly Poly Weight Loss. As always, I am your host, Roly Poly. Please share your stories with the hashtag fatshaming, and please use this as a safe space to discuss your own experiences. And please join me next time.